Hey, Narcotica listeners, this is Troy Farah, your co-host and production manager, here to share with you an exciting bonus episode of a new podcast called Naturally Noncompliant, which is part of Narcomedia. Naturally Noncompliant is a show about people who stand in line and fight for safe supply, namely methadone, the original safe supply. It's produced by the wonderful Aaron Ferguson, who is a longtime producer on Narcotica. We love the work he does here, making our podcast sound great, but he's also doing a lot of on-the-ground drug policy reform work, especially with the Urban Survivors Union. First of all, I just want to say I had nothing personally to do with the production of Naturally Noncompliant, so other than Aaron being a good friend of mine, you're getting my slightly unbiased opinion when I say this show is fucking awesome. It's a little different than how we structure things in Narcotica. It doesn't really have co-hosts, for example, but it really puts the voices of people who use drugs front and center. That's something we've always strived for at Narcotica as well, to give voice to the voiceless, because almost no one in society is marginalized or given less of a voice than people who use certain unsanctioned chemicals. If you listen to this show, I'm pretty sure you already know that. And of course, that bias and bigotry is often compounded for people who are already oppressed in our society, i.e. women, people of color, and queer individuals. We interview plenty of academics and experts on this show, but we always try to platform just regular old people who use drugs as well. And Naturally Noncompliant does that on a whole other level. I really can't wait to have you listen to it. And we're proud to have it be part of the Narcomedia umbrella, which will hopefully keep growing to encompass new and exciting projects that accomplish what Narcotica has always attempted to do, lift up the people who deserve it. You can stay tuned for more from Narcotica. We are working on new episodes and much more. Narcotica is ad-free but listener-supported. You can join our Patreon at patreon.com/narcotica. You can message us for stickers and get a code for our online store, which is narcocast.myshopify.com. More info and stuff at narcocast.com. Thanks for listening, and go join a drug users union and subscribe to Naturally Noncompliant on iTunes and Spotify and wherever you get your podcasts. Enjoy.
Is a drug dealer. Look here in his office drawer. He's got all the bad drugs here. Marijuana joints, pills, Quaalude, Valium, yellow ones, red ones, cocaine grinder, drug needles.
Hey, Tony ain't no crackhead. He's on methadone. He's a recovering heroin addict on methadone.
3 sickly sweet doses of methadone a day instead of smack.
I know the drugs are here somewhere. We're gonna check every crate until we find it.
Here, in Michigan, a young girl, 17 years old, a reefer smoker, taken in a raid in the company with 5 young men.
I act out for methadone.
I'm acting out for methadone because stigma kills.
I'm acting out for methadone maintenance treatment.
I'm acting out for MAT.
I act out for methadone because the clinics are not healthcare.
I act out for MAT because I don't want people to die.
I'm acting out for methadone because everybody deserves access to evidence-based, compassionate treatment.
I act out for methadone because we need to reform the way we treat people who use opioids.
I act out for methadone because everyone has the right to compassionate care.
What are you looking for?
Dope, drugs, weed, grass, toot, smack, quackers, uppers, downers, all arounders. You name it, we want it.
You think the people of this country exist to provide you with position. I think your position exists to provide those people with freedom. And I go to make sure that they have it.
Methadone Diary, Friday, October 23rd. So, there I stood in line for my 13-day take-home re-up, already wasting precious minutes with my 3rd drug swab and as many clinic visits. I swayed impatiently from foot to foot, having nothing to read, since the clinic contracted security guards, in all their wisdom, had long ago decreed that my Kindle was somehow a threat to clinic confidentiality.
I'm sorry.
Even though it had no photo capabilities. My eyes idly roved over the walls, where I saw signage that suddenly stopped my heart. Be advised that many patients will be receiving fewer take-home doses, especially those who have had no contact with their clinicians for more than 2 weeks. I'd gotten complacent here in Massachusetts, the progressive state which inspired Medicaid expansion. I'd gotten complacent in my clinic, which immediately started to offer 13 days of take-homes after the new SAMHSA guidance in March to offer 14 days for patients less stabilized on their doses and 28 days for those who were more stabilized. But I guess the clinic was getting self-righteously sick of fulfilling the mandate to protect our health. Never mind that our small city, the second poorest city in the state, had once again become one of the state's hot zones, and that COVID cases were once again increasing. Sure, the appropriate response to this was to increase instances of possible exposure by necessitating more in-person dosing. Plus, the clinic never did anything without a punitive stick in hand, and since they'd started mandatory groups virtually again, the better to bill mass health with, my dear, they'd needed a way to stick it to people for not going. And come to think, I had called out a group this week, after 2 weeks in a row being the only one to master the clunky WebEx conference call app the hospital used, sitting in excruciating awkwardness making conversation with the sweet Iranian older woman counselor, who kind of reminded me of my mom. Finally, the nurses at the windows seemed to master the light system we'd had for years, and a beacon shone in one of the windows, and it was my turn. I took out my 13 take-home bottles, 6 at a time, then 7, labels front. Then I made them do the do-si-do to show their backs. Some weeks ago, I'd gotten into a great Gatorade debate with a nurse who insisted that the droplet of purple liquid stuck at the bottom of my bottle must be uningested methadone rather than the liquid I'd used to wash out my mouth. So now I was extra careful to lick up any trace of moisture from the bottles. The nurse took her time doling out my bottles while I struggled to affix the date stickers on them as quickly as I could. All the while, she seemed to lean into the window, as if the plexiglass between us could protect us both. Though there was a large hole in it where this all-important exchange could take place. Sweet relief. She gave me the full 13 to take home after all. I started my long climb up those many hills on the hospital campus, clutching my lockbox, only to be stopped by the security guard stationed on top of the first hill.
Excuse me?
There to balefully forbid anyone without a drive-down pass to continue further. He assured me he'd gotten my Mass Health contracted yellow cab driver to park in the correct parking lot several hills over. I told him again, like I had when I passed him on the way in, that I directed him there myself. Well, I asked him and he said, no, you didn't, he had to point out. And of course, whom was he gonna believe, the taxi cab driver or the junkie? Oh, and you left your ID downstairs. They say you can pick it up next time you're here, or you can go grab it now. Sighing gustily, I turned around and retraced my steps. No way was I going to allow the clinic to charge me $5 for a laminated card they printed themselves when they inevitably lost my ID in the interim. I grabbed the card from the security guard stationed at the metal detector at the entrance, and then turned around to once again run up that series of hills to my waiting taxi, making sure to hold the lockbox at a horizontal angle tightly close to my chest so the methadone didn't leak out of the flimsy bottles. I jumped in the back seat of the taxi van, apologizing profusely as I rushed in, shoving the lockbox into the seat next to me. In reply, the driver intoned, no offense, but most people would just leave after 10 or 15 minutes. But no doubt still charge Mass Health for my ride back, I thought, but didn't say. Another day at the clinic. Death from 1,000 cuts, or, in this case, 1,000 bureaucratic irritations. But hey, at least for now, I was lucky enough to avoid iatrogenic COVID-19 exposure for another 13 blessed days.
Hi, I'm Katie Simon. I'm a leadership team member at National Survivors Union and executive staff in 2 of its affiliate organizations on the ground. I do a lot of research and intervention consulting with different entities like universities and research institutions. And I'm talking to Irene Garnett right now, who is a co-author on a study called Nothing Really Changed, which was on the adoption of medication for opioid use disorder regulation relaxation, meaning both methadone and buprenorphine, mutations on the ground in Arizona, and what they discovered in this statewide study. And Irene Garnett was one of its co-authors. One of the incredible things about this study, it was based really and deeply grounded in community-based methodology. And for example, all of the interviewers were people with lived or living experience taking, well, what I like to call opioid agonist treatment, because I don't ever like to have the words opioid use disorder pass my lips. But sometimes we have to say these things to get these things in public health journals. Irene, it is such an honor to be with you today. I have been so long been an admirer of this work in particular. Do you think you can tell me how you got involved with this cast of co-authors, this team, Dr. Beth Meyerson from the University of Arizona, Danielle Russell from Arizona State University, Arlene Mahoney, who is now the executive director of Southwest Recovery Alliance, and many others whose name I cannot remember right at this very moment. How did you get involved with this study in the first place?
For sure, yeah, and just to add, so it's Dr. Danielle Russell now, and she is doing her postdoc over at the university in Australia. But yeah, so basically, I'm super honored to be part of the organization with the DPRAB, the Drug Policy Research and Advocacy Board, and basically, I'm on Shot in the Dark and Sonoran Prevention Work, which is two harm reduction organizations, one I guess in Arizona. On their Facebook page, Danielle put out a post looking for researchers with lived experience to do this interviewing project. So I signed up. At the time, I was working full-time for a nonprofit working with justice-involved women in the prison system. But I was going to do this on the side. And basically, the work we were doing was to reach out into the community of people on MAT and ask them questions about their experience during COVID, when SAMHSA had recommended that the clinics relax some of their standards for the take-home privileges. I hate to use that word too. It's ridiculous, but anyway, so this is something I'm passionate about, and because of all the things that needs to change. So I joined this with Danielle, and then got to meet Beth, joined up with the DPRAB, and since then have been on multiple different research studies that the lab has been doing about syringe access, different things with Hep C treatment. We're doing something right now about pharmacies distributing pregnancy medicines and hormones and all these kinds of things. It's just a dynamic group that I'm excited to get involved with. And basically, I joined it because Danielle put out a call to lines for people with experience.
Can I ask? I know that the DPRAB was very much involved, not just in, we often talk about critiques of community engaged approaches and such in drug use research. We talk about being kind of shunted into subsidiary roles like interviewers. And I know that was more than what the DPRAB did. Like, the DPRAB actually helped interpret the findings, They were there in every step of the way in terms of the process of this study. But I do wonder about, so you weren't just interviewers, and I know that, but I do want to ask about what was the process of interviewing people who had been experiencing the opioid agonist treatment regulation relaxations, or the lack of them, what was a typical interview like? What was a particularly memorable interview that you may have had?
Yeah. Well, and you said a couple of things that were important. The first thing you were talking about, which is that using people with the lived experience as interviewers, but in this case, keeping us involved in the research process and with the findings and all that stuff, which we've been having discussions just recently with the DPRAB about how to be the most equitable with the people with lived experience involved in this kind of academic part of, disseminating these findings in the papers and stuff like that, when a lot of people maybe don't have the academic credentials to, so there, sometimes people get ghettoized with the lived experience. Like, you could do this, you can be a peer support person or whatever, but you can't make the real money as like a counselor or whatever. And not to say that that's real money, but just the way.
No, but you can't take a main role. I know what you're saying. Like, you can be an interviewer, but you can't interpret the findings. You can't help write the manuscript. You can't actually get the credit of this, intellectual labor to your name when it comes to academia. Yeah,
exactly. So, Beth has been amazing in keeping us so involved in every piece of the project. And some of my background, like I have a bachelor's, I have a master's in library science, and I have some of this stuff, but we have people on our team doing the interviewing who their expertise is the lived experience, and that's as valid, as anything else. And so going out and doing the interviewing with folks. So back to the question about the interviewing, that was really interesting. So we had set questions where we wanted to determine certain findings about what the clinics were up to during COVID. And the findings weren't super positive in that most of the clinics were not going by those. And one thing that was interesting, and Danielle really honed in on this, is like a lot of the people we were interviewing, it's almost like they're just so grateful to be getting methadone at all that they feel like all this crappy treatment is justified in some way. So it's like back to this issue of privileges for take homes. It's like, why is that a privilege to be able to live my life normally and go to a 9-to-5 job without having to spend hours in a clinic every morning to receive this medication that's going to keep me involved, kind of thing. But anyway, so the clinics, they tie all the take home. So the people, I'm sure your listeners know, you have to go into a clinic to dose every day with the methadone. And but if you are clean, if you're whatever for a certain amount of time, then you can slowly get these take homes. And my clinic, and pretty much every clinic in Arizona, you have to have 3 months.
Which was the federal standard before COVID-19. And, and in some places it would take longer.
For one day, one extra day, it takes 3 months. So to get up to a week, you're talking like a year or whatever. But during the COVID, they said, look, we can relax these standards. If people are just kind of doing okay, let's give them the take home so they don't have to risk their lives with the infections and whatnot coming into the clinic. So at the time, I'm trying to remember at COVID, I was COVID was a long period of time, but I didn't have any take homes at the time. I got sick a little bit at one point, and they did give me weekly, but that was quickly taken away. My tests were not coming positive for opiates in any way. They did come positive for cocaine a few times, but so I was going in daily, and that was my personal experience. With all the people that I interviewed, I don't think any of my interviewees received the SAMHSA recommended amount of take homes.
Yeah. No, like our clinic, my clinic, for example, immediately set the rule down that the limit for them would be 13 days. Nobody was going to get the 28 days that they said that stable patients were promised in the March 2020 guidance, or were offered. Obviously, the March 2020 guidance was a guidance, unfortunately, as we discovered, and nobody was going to implement it if the states and the medical director of your program didn't agree. You were fucked. And recently, after 3 years of being on 13 take homes, I was dinged down to 6, which is going to be real fun right now for a lot of the travel that I'm doing for work.
13 sounds amazing to me, though.
No, I understand. I spent years. I spent more than 10 years on dailies. And so from that point of view, I can see whoa, even 6 sounds amazing.
Right.
Damn it. But reading this, it struck me what a huge variability there was in implementation. And we saw that from clinic to clinic, but even from state to state. Right. I want to go back to the methods for 1 second and ask you, one thing that I thought was really interesting is that, in the paper you guys wrote that interviewers also had experience with cross sections of communities, such as those that were undocumented, rural and BIPOC communities, and linkages to both treatment modalities of methadone and buprenorphine. Interview recruitment was social and through convenience sampling conducted by the interviewers themselves. So what was your cross section, if you had one, that you were like a community of methadone or buprenorphine patients that you were particularly connected to? Was it people who were recently justice involved? Like when you did convenient sampling, what kind of people did you choose? Like, what did it look like, that process for you?
Yeah, that's a great question. So I had previously worked briefly at one of our big methadone clinics for a brief amount of time. And so I thought, well, maybe I can pull from that because it's one of these large clinic systems for interviewees. But then it didn't seem like they wanted people grab people. So I really had to kind of think about it. So I kind of reverted back to just my social world of as a user out in the community of users and people that I knew of. And that community included lots of BIPOC people. And then, so it was a slightly more social. There were a couple of people that I just kind of knew from that world. So that gave a rapport already. But then there were just total strangers. So we had to do a certain number. And
to reach saturation, like the number that you guys were going for was like pretty high. Go on, please. Sorry.
No. And so I did get on there's one of these recovery Facebook groups that has thousands of members on it. I mean, it tends to be a little more skewed to the 12-step type stuff, but it also includes lots of resources like how to find housing if you're justice impact and all these kinds of things. So I jump on there sometimes, and I did put out some posts on there where I got some responses from people because they were paying our interview. I mean, well, they got like a $30 gift card or whatever.
Right.
Didn't sound like much, but it compensates their time. It took about 20 minutes to go through the questions.
Can I ask, I guess, and this is just my hobby horse in community engaged research approaches. It's like my thing is, I get very angry about institutions or IRBs forcing us to only pay our people in gift cards because, especially when they're store specific, like Vanilla Beast is fine if you can take money out of them. But I feel like, oh God, there was one person I heard at a MRSA, it was ASAM saying recovery appropriate incentives, that we can't choose how to spend our money, that we are consenting adults enough to be able to consent to be in a research study, but we can't be consenting adults enough to decide how to spend the money, that we earned by providing data for this research study, which otherwise, would not exist without us. I'm wondering how did the institution limit you to these gift cards, if you know about that?
Yeah, that's a great question. I think that Danielle was kind of involved in that, and they did receive just little Visa cards, but even so, I totally agree. So I'll tell you, for the past 10 years, I've been involved in a methadone use study through surveys from the University of Washington, St. Louis, and they ask a series of questions about drug use and methadone not use and all this stuff, and then I get a $20 Walmart gift card in the mail.
Oh God! And you're like, thanks.
Back in the day, I used to trade that to people for whatever because that's super, super limiting. And when you're not working years ago when I wasn't, you get these $20.
Right. But that's great that you guys at least got. Like, if you can't give out straight cash, giving out vanilla pieces is the next best thing. So I'm glad that your university and the IRB allowed you to do that at least.
And if I could go on a tangent about the bupe thing versus methadone,
please.
Yeah. So most of my people were on methadone. Now, in my personal experience, I used heroin for 20 plus years, and way back in New York when bupe was just getting started, and I was trying to get on bupe a little bit. The whole partial agonist thing. So what was I'm going to go on a bit of a tangent, but what was attractive about bupe was not having to go to a clinic setting every day, right? And getting that prescription. It was exorbitantly expensive at a time when I didn't have insurance. But then once I did get on Medicaid, it was cheaper and stuff. But because of the whole, having naloxone in there, like the whole getting on the bupe or Suboxone or whatever, how you have to abstain from any opiates for a certain point of time so you don't get kicked into precipitated withdrawal when you take it, was so prohibitive to me in my regular active everyday use that I would just never get on the Suboxone. So this was supposed to be a medicated assisted treatment that is the golden child of the world.
Right,
with,
but it
methadone being
assisting you at all, yeah.
Yeah. And then, but I mean, so it was never effective for me. First of all, the ceiling effect of the Suboxone buprenorphine.
Yes, the plateau.
Yeah. You can, I mean, once you have if your use level is too high, it's not going to be effective. But also just getting on the stuff, that waiting period was so prohibitive. So it made the medication pointless. And so it's really annoying to conflate the bupe and the methadone in that way when methadone is so far superior to somebody who's in active daily use, because you can just get on the methadone, right? Instead of having to go through this crazy process of your body abstaining in order to not get.
They tried to like appease the doctors and appease, the drug authorities by saying like, oh, the naloxone is going to make it impossible to shoot the buprenorphine.
Right.
Naloxone. Whereas it has there's such a tiny amount of naloxone in buprenorphine naloxone that lots of people shoot buprenorphine, or, nobody told them, no, it's because buprenorphine just, binds so hard to the opioid receptors that it just chases everything else out. That's why it causes precipitated withdrawal. And nobody talked to people about how, and like we're seeing this initial evidence of like the difficulty in fucking, people having inductions in the fentanyl era with precipitated withdrawal, with how long fentanyl stays in your lipids, and like fucking, but at the same time, we're seeing like, like the public health system and federal agencies being like so, invested in expanding buprenorphine access when they have the drug that works right there.
Right. It comes with all the apparatus of the stupid clinic system, which, why? But I mean, yeah, I for months was on buprenorphine prescribed to deal with the use, and never took it. And the one time I did try and take it too early and got into that precipitated withdrawal, which was hell. I was on a vacation and it was a nightmare for days. Yeah. So anyway, so methadone I came to a little bit later. And it's great, except for having to go to the clinic every day. And that's why this study was so interesting to me, because I really think the work of the DPRAB in trying to address why all these protocols are necessary for people who just want to get out of chaotic lifestyle and into something more stable. And if that's the way to go, then, treat us like adults so we can just take our medication as we need at home kind of thing. Anyway, so DPRAB is just addressing that, has been really great. With the interviews, most of the people I interviewed were on methadone. It's interesting. I think they'd like to push the buprenorphine more on younger users, and I guess that makes sense. Like if their tolerance level hasn't skyrocketed, and maybe that there's a thought that methadone use is a little bit more restricted, and that it's more
so they don't want to push it on younger users. There actually used to be a federal law, that you could only be put on methadone as somebody under 18 if you had had OUD for a year and you had one previous experience to try to become abstinent without methadone, something like that. And
that's what I'm saying. I think that they were pushing the bupe more on younger people.
Oh, that's what you mean. That makes sense. Yep. Yeah. Along with the way that they push it on white people. Like if you look at Helen Johnson's studies of how buprenorphine is much more accessible in white middle class neighborhoods, whereas methadone is much more accessible in Black low-income neighborhoods, and how the entire restrictive punitive regulatory system out and Whiteout and in all these other and in all her papers is it was created because at the time they wanted to surveil Black people who use drugs, and they thought like this, we cannot have them just taking their opioid agonist at like any other medication. We have to bake surveillance into this system.
And God forbid we make the middle class white community have to go line up in these clinics and get their doses every day with their shady people all around them kind of thing. I mean, you know, I remember when I first got into a clinic and I was one of the few white, youngish women. This was about 10 years ago. And you have to go at 3 a.m. to sign up, you know, and wait to get seen, like before to get into the program kind of thing. And it's sketchy and whatever. I mean, yeah. And then when I went to, prior to that, when I got on the buprenorphine, you go into a doctor's office, you just see a doctor, gives you a prescription. I mean, the differences are so stark.
Totally. And one looks like actual medical treatment.
Man, where the hell is everybody, man? They're getting high, that's what.
Hell, back in the 60s, I used to smoke his shit on the street. Cops didn't say nothing. Hell, he's getting high, too. Everybody was doing it.
All of my friends was dropping out of high school, hanging out on corners, in front of liquor stores, getting drunk, getting high.
What are you doing? Ticketing?
Cause of death was heroin overdose.
I act out for MAT because I don't want people to die.
Intravenous injection of hard drugs.
You got some blow? You got some rock?
I'm acting out for methadone because everybody deserves access to evidence-based, compassionate treatment.
I act out for methadone because we need to reform the way we treat people who use opioids.
I'm acting out for methadone because no one films me when I pee.
Do you mean about heroin?
I'm not guilty. You're the one who's guilty. The lawmakers, the politicians, the Colombian drug lords, all you who lobby against making drugs legal, just like you did with alcohol during the Prohibition. You're the one who's guilty.
I act out for methadone because everyone has the right to compassionate care and treatment that is centered on their life expertise and their own decisions.
Dope, drugs, weed, grass, tube, smack, quackers, uppers, downers, all arounders. You name it, we want it.
I will not die sober.
There's a difference between us. You think the people of this country exist to provide you with position. I think your position exists to provide those people with freedom. And I go to make sure that they have it.